Over to you, sir.
Thank you, Chairperson, for the kind words. And also, I'd like to thank JPEF team for giving me this great opportunity to speak on this very important topic. So, this topic may look very simple, diabetes generally, but it's very, very informative and very pertinent to a clinical practice because we all know that elderly patients need a separate support and care to prevent the complications those who are dwelling with diabetes. So see the daily behind the evolution of the geriatric department across the globe. She is Mary Jory Warren, she is professor of British surgeon. She fought hard in UK to bring out the geriatric department, and she has been considered as the mother of modern geriatric medicine. So this is the roadmap. Some thoughts on the border of diabetes in the elderly population. What is important? Challenges in the management of diabetes in the elderly population. Some inputs on the pharmacological approach. So with the advent of the drive of the modern medication, the therapeutical gadgets, technological gadgets, there is longevity on the rise of India. If you see the life expectancy by 1960 is 42 years, but it may jump to 76 years by 2050. So in those elderly population is growing by threefold higher rate than that of entire population. Invariably, we see the life expectancy of 60 and 80 years has increased significantly. Now standing at 18 and 7 years. Respectively projected to be 21 and 8.5 years by 2050 is very, very fantastic. So, to see the global burden of diabetes in the world population of diabetes, almost, it was around 9.3% in 2019, but it may jump to 195 million by 2030. The sad part of the story is almost 50% of the elderly population more than 65 years of age, when they have the problems of diabetes and the age is more than 65. So if you are able to see the five important countries here, but we stand the prevalence of diabetes among the older population, almost 11.0 million, that is 70% of the older subjects are suffering from this one diabetes among the older population. These are the data from the national survey. What they found, they were analyzing the reported morbidity of age and age in the population, and the mean was somewhere around 30%. Why is it important to consider the elderly as a separate group in the management of type 2 diabetes? Because this is the pathophysical link between the diabetes and also concomitant obesity, sarcopenia, and type 2 diabetes. Aging contributes to the pathogenesis of type 2 diabetes, both directly decreasing the beta cell function as well as reducing insulin secretion. See, if one side the aging and the other side is obesity, is totally bidirectional. Aging contributing by sarcopenia, sexual muscle dysfunction, frailty, and so on and so forth. Obesity, once again, insulin resistance, central obesity. These are all contribute for the decrease in insulin secretion as well as the insulin resistance, and thereby contributing for more and more diabetes, complicating both microvascular and micro complications. So among the common clinical conditions, almost 60% of the type 2 diabetes elderly population have this at least one comorbid condition, especially with the cognitive decline, retinopathic problem like Madam was already alluding about that, sexual dysfunction, so on, so forth, polypharmacy disability. Depression is one of the main menace among the elderly population. So these are the things we want to get support. And other things, 40% couples with the urine incompetence, there's urine incontinence, the heart and visual impairment, falls and fracture due to sarcopenia, cardiac disease. There are multiple comorbidities. So these make the clusters of complexity in the management of diabetes among the elderly population that very, very important to be advocated in clinical practice before seeing the patients here. So eventually, if you see the diagnosis of the diabetes among the elderly population was fascinating. See, 2 hours plasma glucose in the OGTT are more reliable than the fasting sugar. Fasting sugar in the early stages may be normal, but 2 hours plasma glucose appears to capture underdiagnosed cancer, but A1 is somewhat less sensitivity. And also, if you see the osmotic symptoms are less prominent because they have the increased renal threshold for glucose, reducing the intensity of the polyuria, doesn't fill up polyuria, doesn't fill up this one polyuria, and therefore there is the diagnosis. And diagnosis and diabetes among the elderly population totally asymptomatic about 50% of the populations. And more than that, if you see the assessment, rather than with the chronic microscope complication, but we have to assess both physical and neuropathic functions as well as the mental and cognitive functions, very, very important. Because cognitive impairment is very large menace among the elderly population of the diabetes we want to consider in our mind. Alan Sinclair clearly amalgamated the prevalence of both vascular, physical, and mental complications, mental dysfunction contributing by dementia, depression, behavioral and anxiety disorders, this physical neuropathy complications, sarcopenia and frailty, accompanied with the vascular disease like microvascular, retinopathy, nephropathy, and so on and so forth. It is totally interlinked and amalgamated, it is clustered totally, and will lead to the disability, including visual loss, both chronic macroscopic microscopic complication, going for more and more morbidity and mortality among the daily populations. What are the challenges we have in the management of diabetes in the daily population? So these are the comorbidities. We know that they have delirium or progressive cognitive decline. And therefore there are consequences like irregular food intake, refusion of glucose content. These are the common thing we see in our families among daily populations. And more than that, if you see a refusion of medication injection, if you prescribe basal bolus, they will take only the basal, they miss the bolus. If you take 2 or 3 times medication, they will take only one time medication, miss the 2 medications. So we want to simplify the medication regimen by means of strategies. Frailty is important area to be considered. So deconditioning pressure ulcers, required assistance should be considered. Depression, maybe the partner loss, isolated feeling, weight loss, weight gain, refusion of activities, glucose monitoring. They don't do glucose monitoring also, therefore they are predominant for hypoglycemia, skin infection. So these are the management strategies we want to implicate, and by advocating the patients, not only the patient, and by family also should be advocated accordingly to prevent the complications. Even the multiple times UKPDs insist the physicians across the globe to emphasizing on the intensive glycemic control, and have been addressed for the microscope complication, but the macroscope complication they are constant. But in elderly population, you go for intensive glycemic control. There are the challenges because those patients have sarcopenia, frailty, and fracture. If you go for hypoglycemia, it will impact the quality of life because it will lead to the complication, including the dead-in-bin syndrome and autonomic neuropathy, may precipitate to cardiovascular complication, including fibrillation. So we want to keep in mind for tight glycemic control, make it relax, and all the global societies also require the same only. Sarcopenia is an important area challenge. Should be always think among the elderly population diabetes because sarcopenia is accompanied with muscle loss, muscle function, is muscle intensity also. And if you see the age more than 60 almost, there is around 35 to 3.5 to 5.5% of muscle loss among the population. If it is contributed by aging and it is contributed by diabetes, it is precipitated by vascular inflammation, oxidative stress, so on, so mitochondrial dysregulation. This will increase the comorbidity as well as the outcome very badly. And therefore, elderly patients with diabetes are 2 times more likely to develop the sarcopenia than those with diabetes. And sarcopenia contributes to functional impairment and increased risk of mortality in elderly patients. We want to specify the treatment because we know that SUs are the impact of sarcopenia. We want to prefer the SUs or DPF inhibitor like sitagliptin and linagliptin have more outcome benefit regarding the sarcopenia among the elderly populations. This is very important aspect in the clinical practice. Whenever you see a patient with multiple loaded medication prescription polypharmacy, please consider about the de-intensification diabetes care. What is meant by de-intensification? It is can do de-prescribing, reducing the diabetes specific assessment and no longer improve the quality of life. Because any molecule the patient doesn't need means we want to cut the molecule. Why we want to do? Because those the patient who have the short life expectancy, low cognitive function, low function status, patient refers to our less intensive, severe, high number comorbidities, long diabetes duration, vascular complications. So these are the challenging areas we want to see. So by means of de-prescribing anti-diabetics, switching to another drug with lower risk of hypoglycemia, de-prescribing other medications like because after the age of 30, I think this statin will not be helpful for the patient. So we may consider reduce the statin, stop the statin in the patients. Anupama Madam was clearly alluding the importance of this post-menopausal among the diabetic patients. Post-menopausal state is very, very important among the diabetic patients, elderly population with diabetes among the female because it may dysregulate the BMR. These will end up in the vascular adiposity, adipocancer, endothelial dysfunction, and contributing by depression as well as the vasomotor symptoms and going for both cardiovascular complications and cerebrovascular complications. So we have to keep in mind, we address all the factors, not only the glycemic part, with the lifestyle modification, glycemic control, management of BP, lipid management, anti-platelet therapy, aspirin therapy, and Madam was reading about the HRT, that's hormone replacement players, an important role in the post-menopausal state. Thus, once again, this inpatient care is very important because this elderly population may contribute both for hyperglycemia as well as hypoglycemia. But Rather than hyperglycemia is very, very enhanced because this intensive glycemic control will have the impact on hypoglycemia. One single hypoglycemia patient will go for the massive cardiovascular complication leading to the especially ventricular arrhythmia or ventricular fibrillation, atrial fibrillation. So we want to keep in mind patient-centric approach is very, very important. Insulin therapy, regardless of patient needs, may be considered. A D4 inhibitor plays a pivotal role in the management of diabetes among the elderly populations. Now we come to our part of pharmacological approach for diabetes in elderly populations. Multiple societies, ADA, AAS, American Geriatric Association, AC, are clearly emphasizing us. Follow the aspects of HbA1c target according to the patient need. That is, if the patient are independent or dependent means lacks the criteria. So HbA1c goal for most healthy elderly person with intact cognitive and function disorders keep and maintain the HbA1c between 7 to 7.5 and AS accommodating less than 6.5 and American Geriatric Association advocating with their 7 to 7.5 if they are independent. But if they are dependent, they couldn't be able to follow their own words. We want to relax the HbA1c. Don't be more tight on the HbA1c. That is a message I want to render my dear friends here. So make the HbA1c between 7.5 to 8. That is the ADA, American Geriatric Association, emphasizing between 7.5 to 9 and AS more than 6.5 and ACP that is not any specific because see maintain the HbA1c back somewhere around 7.5 to 8 and more than 18 means you can maintain more than 8 also. There are no problem over that. So in cut short, if you see the management, if they're independent, partially dependent and dependent. So independent means management, nutrition, adequate nutrition, high protein diet, target tight glycemic control once again, goals can be maintained. Partially dependent, adequate nutrition once again, but see the HbA1c should maintain between the 7 to 8%, prevent the hypoglycemia and maintain the function, prevent of the risk of disabilities. Dependent is very, very important. Any age patient more than 75, more than 8, want us to hold adequate nutrition. Very important protein intake also. It's very important to build muscle loss. But see the HbA1c, we have to maintain between 8 to 9. That's very, very important. Ensure treatment safety. Support the patient. Educate the patient, not only the patient. Educate the family also. Our own family will have multiple elderly patients. So we have to keep in mind and we have to treat the patient over that. ADA, emphasizing elderly adults with type 2 diabetes at an increased risk of hypoglycemia. This is important. So medication should be adjusted according to prevent hypoglycemia. Over-treatment diabetes, over in elderly adults and should be avoided. De-intensification, de-prescription is very important. Not load the medication. Make it very, very simple. No lot of B complex, no multiple therapy, no statin-based, I hate statin-based therapy because that also may potential for sarcopenia. Should be considered cost factor because most of the elderly population they have to spend their own packet. We know most of the elderly patients in their own family they couldn't be able to support the financial status. That's very important. So this is a picture of all available things for the diabetes management among the elderly population. But to see the context regarding the issues are very good, but predominant for the hypoglycemia. So we want to keep in mind. So prefer the issues. Avoid the glyburate and glycemic. So say the insulin, prefer basal insulin or prolonged insulin to prevent the hypoglycemia should be considered. And insulin pattern is very, very important. So if a patient already under insulin, the patient getting age more than 75, more than 8. If the patient already under basal insulin, change the basal insulin from morning to the bedtime. The patient under mealtime insulin more than 10 units means reduce the dose by 50% and mealtime insulin less than 10 units means stop the insulin and go for some other non-insulin regimens. Patient on pre-insulin, use 70% of the total dose on basal only in the monitoring in the morning and follow algorithm for adding non-insulin regimens. So these are the insulin regimens we want to categorize in our clinical practice. This is very, very important message. So already telling about the OHS therapy among the elderly population and also alluding about the algorithm regarding insulin initiation, intensification, also titration. So once again, metformin is a good molecule, but there are challenges in metformin because metformin are a lot of controversies across the board. Still it is the area algorithm, AS algorithm, but we have a lot of controversies. It has this one, the GI disorders, vitamin B12 deficiency. This is a hypoxia, sir. Pulmonary hypoxia, sir. Metformin, contracting heart failure, so on and so forth. So metformin keep in mind, but should be indicated according to the patient needs. new kid to the block, very good, proven molecule, but the EGF are less than 30 should be keep in mind, germatomacotic infection, so on and so forth. So SUs once again, weight gain, hypoglycemia, caution to prevent the weight gain, glitazones once again fractures, and CKD, so on and so forth. Depot inhibitors, one of good molecule, we can prefer enagliptin, sitagliptin, telling good molecule, proven molecule, a bill also you can give, but dosage titration is very, very important. If they have the CKD, but doesn't with the enagliptin, enagliptin. So, a physician once said the best medicine for humans is love. Someone asked, what if it doesn't work? He smiled and said, increase the dose. That is the thing for elderly population. We want to get the extra support, extra care, appropriate support, appropriate diabetic education, not only for the patient, for the family, because our family also have multiple elderly population with diabetes, so keep in mind, and we want to prevent the complication and return the good quality of life. Thank you for the great opportunity. Thank you very much.